Yeah, all the participants, welcome all the participants. Now we can start our webinar now. Additional Secretary sir will join soon in 5 or 10 minutes. So meanwhile, I request Rati Balachandran madam to kindly start this webinar.
Madam, please unmute yourself.
Yeah.
Madam, please unmute
Yeah.
yourself.
Okay. Yeah. Welcome all to the first webinar on the role of staff nurses in newborn care by the Ministry of Health and Family Welfare, organized along with the states and UTs. Respected senior officials from Ministry, expert panelists, state child health, ASHA and maternal health nodal officers, doctors and nursing staff from SNCU, labor room and NBSU, district officers, labor room in charge, representatives from the professional bodies like Indian Association of Neonatal Nurses, Society of Midwives India, All India Federation of ANMs and LHV, development partners at national and state levels, academicians, regional and national collaborative center focal points, child health teams. Each and every one of us are an important pillar in India's journey to reduce newborn deaths, and we are committed to ensure every newborn is able to survive and thrive and transform into a productive citizen of our country. We all are celebrating the National Newborn Week 2020 on the theme ensuring quality, equity, and dignity of newborn care at every health facility and everywhere. The structure of today's program is we begin with the introductory session, followed by 4 technical sessions by the nursing experts, sharing of state experiences and question answer session, and end by the remarks of senior Ministry of Health and Family Welfare officials and vote of thanks. Now, few housekeeping rules. As we have a packed agenda, requesting all the speakers and experts to follow the time allocated to them. All participants will be on mute with videos off to allow least distraction during the presentations. For any query, please post your comments on the chat book where our group of experts will be continuously interacting. Any of our colleagues or participants are facing issues in logging, you can use YouTube link, which we will be sharing in the chat book. To begin the deliberations, the introductory session was supposed to be by the additional secretary. As he is busy in the meeting, I request Madam Dr. Sumita Ghosh, Additional Commissioner to the Child and Adolescent Health, to make the presentation on the status of facility-based newborn. Dr. Ghosh is a pediatrician having more than 35 years of experience in health sector and has led maternal and family planning programs at the national level. Over to you, Dr. Sumita Ghosh.
Presentation. Yeah. Thank you. Thank you, Rati. Namaskar. Good afternoon. I welcome all the participants today from the nursing fraternity for this very important webinar on the occasion of National Newborn Week, which is being celebrated from 15th to 21st of November, as every year it is being done. And this year it is special because it is happening in when COVID is looming large on the whole world, and this is done in an e-mode, and that has actually increased our reach, as we can now reach to every nook and corner of the country through this media. It is rightly so that our this is the first program for the National Newborn Week, and rightly so, because I do believe that nurses, nursing faculties and fraternities, they play a pivotal role in healthcare system of our country, both maintaining the quality as well as the coverage of care. They are involved in provision of care as well as experience of care. The second part is very important because they are close to the patients, they are close to the families of the patients, they are closer to them for a large amount of time, and thus they influence the experience of care of the patients, and it is an important pillar of quality. So I hereby start my presentation on facility-based newborn care in India. This year, as already Rathi has told you, that the theme of Newborn Week is quality, equity, and dignity for newborn care at every facility and everywhere. So here I begin. Next slide. Next slide. So here we began because we saw that institutional deliveries were increasing in our country, whereas the newborn care system was not getting developed, and there was ongoing health system strengthening, and there are supports from all kinds under NHM. So we thought that along with the institutional delivery, this facility-based care for newborn should also be defined, and they should increase, and they should be of standard qualities. So this program began in 2011. The successful piloting was done in West Bengal at Purulia district for the facility-based care. Next slide. So we have a tiered system. 3 levels are there. At the low rooms and obstetric OTs, we have newborn care corners, which is the first point of contact. And if there are any problems, then there are first referral unit level, we have newborn stabilization unit. And for moderate small newborns, and if the problem increases, then they are being catered to. Services are being offered at district level and subdivisional hospitals also, and medical colleges at the special newborn care unit. And at the tertiary level, at higher level, at APEC institutes, we have neonatal intensive care units established. So this is the level of care in our facility-based system. These are all we have done over the years. We have implemented various guidelines prepared for it. We have improved upon the infrastructure, human resource, logistics, budget for establishment, and as well as for recurring cost. The most important pillar had been the capacity building through various training packages, and I'm happy to announce that these training packages are getting revised. Tomorrow it is being released by Honorable HFM. We have established a system of Apex Institute as resource centers to help in training as well as mentoring of our healthcare providers. Then we have developed a very systematic online reporting system for real informed decision on the reports. So it is working. Almost 90% of SNCs are now reporting online. We have supportive supervision, regular reviews. We have given SOPs. We have given checklists. We have collaboration with all our partners by experts, and so that the system performs well. So these are our various publications which Ministry of Health has come out and disseminated to the states on various programs which we are conducting all over the country. We have guidelines on facility-based newborn care, home-based newborn care. Then we have guideline on JSSK. We have India Newborn Action Plan, which I'll come to later. We have guidelines on lactation and management centers, antenatal corticosteroid for mother care, family participatory care. For all aspects of our programs, we have detailed guidelines which to guide the states and the facilities to take proper care, as well as for management and for monitoring. Everything is included in detail in these guidance notes. For survival of newborn, we have this India National Action Plan, which is a special strategy for the newborns and covers 6 pillars which are related to newborn health. We all know that the health of newborn does not begin when it is born. It is much before that. It is in the preconceptional stage, when the mother is innocent or deficiency. So again, there are problems with the newborns which are to be born. So we start at that stage before preconception, then continue into the antenatal period. Then the most important is during the labor and focus area, because 40% of our neonatal deaths occur in this period, and as well as maternal deaths. Then most important pillar again, care of healthy newborn after it is born, then care of small and sick newborn, that is which our facility-based system in NBSU and SNCUs care for. And once the newborn survives, we have programs for, and here comes various nutritional initiatives, immunization. We have RBSK program and several other programs which look so we have, for each pillar we have several programs outlined, and to strengthen our facility based system and for improving the survival and well-being of newborns. Because we know the newborns are very delicate, they are vulnerable, their health is fragile. So we have to look into each and every aspect of their health. And we are committed to bring down neonatal mortality to single digit and also stillbirth rate to single digit by 2030. So the program begins in labor room. As I said, it's about strengthening of delivery points, delivering of quality care at the first referral units where complicated cases can be referred for cesarean section as well as for blood. These are the first referral units at the block levels. We have MCH wings at hospitals been created, Suman program, which in a way assures quality care, that has been launched. Capacity building programs, as I said, there are many, you may be knowing them: Daksh program, Dakshata program, Laksh program, and for neonates, we have several programs that facility based newborn care trainings. We have arranged for free referral transport under child age. Free drugs and diagnostic initiatives are there, and there are activities to IC activities, education, information, communication, for demand generation and for having redressal system and patient feedback system. So all these have been developed to look into the quality and coverage of our newborn care. So presently, this is shows the 3 levels which I have talked about. We have in India about 26 million babies, and 10% of them, the newborn care corners, NBSU, SNCU are already spoken about them. They are, in a chain of system, so that appropriate level. Till now, around 900 SNCUs have been established, and 80% of our districts in the country are having functional SNCUs. 19,000 neonatal beds have been created, and they are catering 24/7 for comprehensive care of small and sick newborn in these SNCUs. 10,000 providers have been trained. 90% SNCUs report online. I have said real-time monitoring. Last year, 1920, 1.1 million newborns have been treated in this, and more than 2,500 NBSUs at the FRU CSC level are there, and 20,370 newborn care corners. So you can see the massive effort and investments and interventions that have gone for newborn health in India. And with these efforts, we are catering to this large cohort of 26 million babies born each year. 15 to 20% of them are preterm, low birth weight, and approximately 10% of total babies, they require some kind of facility-based care. At present, the mortality rate of neonates is 23 per 1,000 live births as per SRS 2018, and most of the days they are occurring in the first week of life, 78%. And there is a steady decline in neonatal mortality rate over the period of time. From 90 to 2018, the world average has reduced by 51%, whereas we have declined NMR by we have been able to do it by 60%, which is much more than the global average. If we look at the causes, they are basically many causes, and 48% are basically, if we can treat the premature and LBW, low birth weights properly, 48% can be avoided. Next comes birth asphyxia and trauma. Here again, our labor room staffs are here. So proper management of labor and interpartum services are very important, as well as neonatal resuscitation comes into this group. Then after that comes infection. There are many severe infections that are causing approximately 12% respiratory related deaths, respiratory system related deaths, and 5.4% sepsis related deaths. Apart from that, goal is to make it single digit by 2030. SDG goal is less than 12. So what are the roles? As I said, we have the nursing faculty, nursing fraternity. They have very pivotal role to play. The normal baby, the normal standard procedures need to be followed. Delayed cord clamping, neonatal resuscitation, routine care. Then if there is any complication, proper referral. Breastfeeding is the very important initiative, very low cost but high impact initiative. Early initiation of breastfeeding, keeping the baby and the mother together as far as practicable, monitoring the vital signs and maintaining and updating records in MCP cards, and counseling of the mothers and family members on exclusive breastfeeding, home care, how to care for low birth weight babies and preterm babies at home. So these are the expected roles. For small and sick newborn, again, we have identified, and that this is very important, this platform I want to use to tell you that follow all the standard operating procedures which have been given for admission, as well as clinical protocol at the SNCUs and NICUs regarding antibiotic use, IV fluids, rational use of oxygen, following the resuscitation procedures properly, using oxygen properly and not overdoing it. Kangaroo mother care is again an intervention, very effective and low cost intervention for the preterm and small small low birth weight babies, small for dead babies, for skin to skin contact. Feeding policy is used as far as practicable. Mother's milk is the best. A rational use of antibiotics. The IV fluids, again, we have to be very careful. Infection protocols in SNCUs and other facilities, again, it can prevent a large number of deaths by sepsis and infection. Keeping records properly of both the patient care as well as drugs, equipments, and keeping a close vigil on the quality indicators in the SNCUs and other facilities. What is the mortality rate? What is the infection rate? Next slide. And what is the successful discharge rate? So these are very important. This lecture will not be over, or my talk cannot be over in this time, in COVID time, when we must see that we protect ourselves during COVID time, how we organize our SNCUs, how we use our PPEs, personal protections, and how we support breastfeeding and kangaroo mother care during, even if the COVID pandemic is looming large, we must, as far as practicable, we should follow the normal routine and prevent any disruption. So protect yourself also against any kind of infection in this time. Thank you very much. I am short of time, I think. So I end here. This forum will be open for questioning and others afterwards, but right now we need to rush. Thank you. Thank you for your patient hearing.
Yeah. Thank you, ma'am, for enlightening about the various initiatives of Ministry of Health and the facilities available for the nurses to ensure babies' safety. Thank you very much. Without much delay, let me, it's my honor and delight, I am delighted to invite eminent personality and the Florence Nightingale Awardee 2008, and Ms. Parul Datta for chairing the next technical session. She is presently the Vice President of Indian Association of Neonatal Nurses. And this technical session, we have 1.5 hours total. So without much delay, I am handing over this to Ms. Parul Datta. Over to you, Madam. Madam Parul.
Yes, thank you very much, Madam Dr. Ruthi Balachandran. Very good afternoon to everyone. Thanks a lot to Dr. Monhar Ragnani, Additional Secretary, Dr. Shumita Ghosh, Additional Commissioner, and Dr. Kapil Joshi, Senior Consultant, Child Health Division of Ministry of Health and Family Welfare, Government of India, for giving us this opportunity and for organizing this session by the nurses to talk about role of the nurses, role for the neonatal care by the nurses only. Welcome everyone for this session in National Newborn Week Celebration 2020 with the theme ensuring quality, equity, and dignity of newborn care at everywhere and every health facility. In this session, we will talk and discuss about important aspect of facility-based newborn care for sick and preterm low birth weight neonates, with special emphasis on latest recommendation to improve the quality of care to achieve the target of India Newborn Action Plan 2030 to achieve single-digit neonatal mortality, and also to reduce the neonatal morbidities and long-term consequences of perinatal complications. We know nurses are key healthcare providers for neonatal care. We are contributing with our best effort at facility and community level to provide optimal care to the newborn for intact survival with do no harm principles. But we have to improve our quality of activities in all levels for better health outcome of the newborn infants. Let us listen from our first speaker of this session, Madam Jessie Saji Paul, on role of nurses in labor room for care of newborn at birth. She is Senior Nursing Officer at AIIMS, New Delhi, and she did MSc on Child Health Nursing. She is national faculty on top course for essential newborn care for nurses conducted by Division of Neonatology, AIMS, New Delhi. She is certified for quality improvement training by IHI USA. Over to Madam Jessie Ford.
Thank you, ma'am. Good afternoon, all the dignitaries on the panel and the dear participants. At the outset, I would like to thank Dr. Manohar Agnani, Additional Secretary, Ministry of Health and Family Welfare, Dr. Sunita Ghosh, Additional Commissioner and in charge of Child Health Division, Dr. Rati Balachandran, ADG Nursing, and Dr. Kapil Joshi, Senior Consultant Newborn Child Health Nursing, and my institute for allowing me to participate in this program. As we are celebrating the National Newborn Week, let us introspect ourselves. What is our role as a nurse in mitigating the neonatal mortality and morbidity? A brief discussion on this. What is the importance of care at the newborn? Because we as nurses has a great role by doing monitoring and timely intervention and or timely referral, and by providing essential newborn care immediately after birth, we can definitely reduce the incidence of death. So if you look at the newborn care facility at different healthcare levels, if I'm in a primary health center or in a community health center or in district hospitals, we know for all the newborn corner is a common facility in all the facility or the point of delivery. So what is the importance of this? Next slide, please. So if you look at the baby who is in utero enjoying the protective environment, irrespective of the place where he is born, the basic need of a newborn at the time of birth is warmth, breathing, nutrition, and infection prevention. And the basic aim of the care which we are providing in the labor room also focus on prevention of hypothermia, establishment of respiration, establishment of breastfeeding, prevention of infection, and detection of life-threatening anomalies. Next. So as nurses, when we are coming onto for the duty as we are coming, so our duty is to make sure that everything, whatever we needed for the baby to be received is working condition and it's present over the newborn care corner. So it's always better, rather than recalling from the memory, it's always better to have a checklist. In all the shifts, we can just check it, whether all these things are there or not, like radiant warmer, whether it's functioning or not. The neonatal ambu bag of the volume like 250 to 500 ml, is it there or not? And with the face mask of different sizes like 0, 1, 2 numbers, and mucus extractor, infant tray with clean clothes for draping the baby, oxygen cylinder, whether oxygen is there or not, with the flow meter working, nasal catheters, laryngoscope with the different sizes of blades, endotracheal tubes of different sizes, stethoscope, weighing scale, injection adrenaline, is it available or not, and normal saline, and all the equipment so that we know we can face it. We can receive the baby timely for that. So as the mother come to the labor room, we know, we take the history of the mother. So if the woman is suffering with hypertension, diabetes, or any other like heart disease or any other problem, if I'm in a primary health center, definitely I would like to refer this case to the higher referral unit, because I know I will not be able to manage this at the primary health center. So in utero transfer is more safer than waiting for the delivery to happen and then transferring. So the normal, if it's a normal case, we'll admit in the labor room the woman and we start doing the monitoring. Of course, we have to use a simplified partogram. So that is a tool which can help in taking the decision as well. So in a partogram, we know the particulars of the mother is written over there. And in the first block, we know the well-being of the fetus is there, like every half an hour, we have to plot the heart rate of the baby fetus. And the cervical dilatation, we have to start with the active labor, like 4 centimeter of dilatation happen. And that has to be plotted on the alert line. So at any time during the progress of labor, If that alert line is crossed, that means the progress of labor is not normal. So this is where we have to take the decision whether any other escalation of medication or is there any referral needed or not, so that appropriately we can take the care and step for a treat the case. And the other or that after taking the decision, okay, it's there, the mother is the woman is still in the labor room with us, so we'll do the further management by preparation, ensuring that the WHO 6 cleans are following, like 6 clean attendance hand, clean delivery surface, clean cord cutting instrument, clean cord clamp, clean cloth to cover the baby, and clean cloth to cover the mother. And also that the delivery room should be warm and draft free. Especially in northern India, we know the winter has come, so we have to make sure that, so that baby won't get hypothermic. And the Lakshya program, we know the birth companion is allowing nowadays. So as per the mother wish, we have to allow the birth companion to be accompanied. And in the COVID pandemic, we know we have to follow the standard COVID protocol also. So as the labor has progressed and normal delivery is happening, we know that we have prepared ourselves, we know, and we have received for that. So we are receiving the baby at the time of birth, we know. If we'll call out the time of the birth, and if the baby is breathing, is crying well, so we deliver the baby onto the mother's abdomen. So as we have delivered the baby onto the mother's abdomen, and we'll turn the face to the one side, if dry, and discard that wet linen and cover with the other second linen, along with mother and baby will be covered, and we'll clamp the cord and cut it after 1 minute. And if any secretion is there, then we can just wipe it. There's no need of doing any suctioning. And then we'll continue with the skin to skin care, and we'll initiate the breastfeeding. That is the routine care which we are following. And afterwards, and the other situation could be like the baby is not breathing. So what we have to do, we'll just clamp and cut the cord and take the baby to the radiant warmer, which is already prepared. We have warmed it beforehand, so it's warm. We'll take care of the prevention of hypothermia, and we'll place the baby under that radiant warmer, and we'll position the head and neck slightly sniffing position we'll give. We'll clear the mouth and nose in case any secretions are there, and then dry and stimulate by rubbing the back, and we'll reposition. So these are the initial steps we do, and we'll assess the breathing. So if the baby is breathing well, so again the baby can be taken back to the mother's abdomen, and then positioning is done, cover the baby, and we'll initiate the breastfeeding. So, and we'll do the monitoring. That is called the observational care. So in case the baby is not breathing after that initial steps, so what we have to do now, we will be doing the bag and mask ventilation or positive pressure ventilation. And there, that point of time, we don't need to be monitoring we don't need the oxygen to be started. So in case that, so we'll initiate the bag and mask ventilation. We'll give 5 breaths. And if the chest raise is okay, we'll continue for 30 seconds, and then we'll reassess. And after, if the baby is breathing, again, the baby can be taken for observational care. And if the baby is still not breathing after that 30 seconds of positive pressure ventilation, that time we need to call for help also. So the helping person should be of experience to do the intubation, compression, and giving medication. So meanwhile, we'll be continuing with the bag and mask ventilation for 30 seconds, and then we'll assess for the heart rate and breathing also. If the heart rate is more than 100 and baby is breathing fine, the baby can be referred to the SNCU. Otherwise, we'll stabilize again by doing the continuing with the bag and mask ventilation. And in case the heart rate is not rising, then we can add on to the chest compression also. And meanwhile, we'll also inform the SNCU so that they can get ready for shifting the patient. So next slide, please. So in case the chest is not rising, so after that 5 initial positive pressure ventilation, so the corrective steps has to be taken before that complete 30 seconds. So what are the corrective steps we are doing? That is a mnemonic which is given, MR SOPA. M for adjusting the mask to ensure good seal on the face. That means the mask should be covering the chin, mouth, and the nose. That is the appropriate size of the mask. It's like 0 for the small baby and 1 for the larger babies. And R for reposition the airway by adjusting the head to the sniffing position, or by repositioning the shoulder pad, we can do the sniffing position. S for doing the suctioning the mouth and nose if the secretions are present, or for opening the mouth slightly and move the jaw forward, because sometimes while applying the mask, what happened, the mouth get closed. So in that case, we have to open that mouth. Then pressure, increase the pressure to achieve chest rise, because of the poor compliance, we need to give little more pressure in the initial period. And A for alternative airway like intubation and all. Next slide, please. In case if we are giving a chest compression, these are the two methods which we are doing, like thumb method and 2-finger method. So correct measures is like 1/3 of the AP diameter we have to compress, and the frequency of the chest compression. Next, please. And as we are settle the baby, so once the normal situation, the baby has to be on the mother's abdomen, enjoying the skin-to-skin care, and initiated the breastfeeding. So meanwhile, we'll also arrange for giving vitamin K. So why we have to give vitamin K? It's promote the synthesis of vitamin K dependent clotting factors in the liver, which will help in reducing the incidence of bleeding. So for that, we need an injection vitamin K that is available as 1 milligram per ml or 1 milligram as 0.5 ml. So we have to make sure what preparation we have, and accordingly we have to take the dose. So dose depends on the birth weight of the baby. If the baby weighing more than 1000 milligrams, 1 milligram of vitamin K, and if the baby's weight is less than 1000 gram, we will give 0.5 milligram. And where to give? We will be giving it on the anterolateral aspect of the thigh, that is intramuscularly we have to give, as it is shown in the picture. And for giving an injection, we need a 26 gauge needle and a 1 ml syringe. And of course, after giving, we have to do the documentation as per your policy in your area, like in a labor room register or in a case sheet, or if you have a referral slip or discharge ticket, wherever it's appropriately you're doing, you must be doing it properly. Next slide, please. And you can also give, so like we have said, after 1 minute, the delayed cord clamping, we'll cut the cord. So, and applying the clamp 3 centimeter beyond the base of the cord, and it should not be too long also, because in case it's too long, it can go inside the diaper and it gets soiled. So always remember, when we are tying the diaper and all, the cord should be above that. And in case the baby is having more of eye discharge, we'll be giving the eye care. And for giving eye care, we need different swab for each swab for each eye, and the stroke should be from inside to inner canthus to outer canthus, as it is shown in this picture. Next slide, please. So we have given the eye care, cord clamp has done, and we'll be monitoring the baby. What are the things we have to monitor? Respiratory rate, heart rate, chest indrawing or grunting, and body temperature every 15 minutes interval for the first 1 hour, and 30 minutes interval for the second hour. So that we know that the baby is transition from intrauterine to extrauterine life is smoothly happening. Along with that, we can also look at the baby's color, baby's activity, and any birth injury or any congenital malformation. We have to screen the baby, and umbilicus observe for any bleeding. So next slide, please. So the clinical screening is important to rule out for any life-threatening congenital malformation is there not. So like from the cephalocaudal, if you head to toe, if you look at oral cavity, we have to rule out for a cleft palate. And if any excessive frothing is there in the baby's mouth, we have to doubt for the esophageal fistula. And during this displacement of heart to right side, obviously the heart should be on the left side. But along with the respiratory difficulty and difficult resuscitation, if it's there, we have to doubt whether the baby is having congenital diaphragmatic hernia or congenital pneumothorax is there or not. And we have to observe the umbilical cord number of vessels. Normally, umbilical vessel will have 2 arteries and 1 vein. So if only 1 artery is there, that means the baby is having some other malformations. So, and of course, we have to look for the anal patency and back for any swelling or anomaly. So after that, after screening that, we have to identify whether our baby which is born is at-risk baby or not. So who are the at-risk babies? Whose weight is less than 1800 gram, at the gestation of the baby is less than 34 weeks, or baby having any congenital malformation, or baby with asphyxia, baby with breathing difficulty, or with jaundice. All these babies you can categorize as at-risk babies, and these babies has to be sent to the SNC for further management or observation. Before that, always remember we do all the shifting out from the labor room, we have to put the identification tag and documentation in the birth registry is also to be done. So we know even in the crunch of shortage of staff, we do all these things as per the SOP so that we can provide quality care to the baby as well as the mother. So it's even in the Apex Center where I am working, we also have the crunch of staff shortage. Still, we try to implement all the steps which we are doing it. Next, please. So from me, the take-home message is that most of the neonatal deaths occur during the delivery or on the day or for the first 7 days, which can be reduced by us by diligent monitoring, preparedness, as well as improving our own practices. So by providing warmth, breathing, nutrition, and prevention of infection, these are the basic need at the time of the birth for a newborn baby, or we can say it's the essential newborn care. We can help our babies to have a smooth transition to the extrauterine life. Always better to have an audit so that we can improve the steps which was missing in for the next case. So that is called as the quality improvement. So each newborn is in the building block of our nation. Hence, we the nurses have an important role in nation building by ensuring quality, equity, and dignified care for the neonate at all health facility. It starts before the antenatal period and beyond. Thank you.
So thank you, Madam JC. You have talked and highlighted about important aspect of neonatal care at birth, with special emphasis on prevention of preparation of newborn care corner, 6 clean practices, use of autograph, neonatal resuscitation guideline, skin-to-skin contact, routine care at birth, delayed cord clamping, and screening of congenital anomalies, along with identification of high risk or at risk neonatal conditions at birth, which required immediate admission to the SNCU for facility-based newborn care. So hope this presentation will help the nursing personnel working for the newborn in different area will be more motivated to provide better care for their tiny patients. So thank you again. Now we all know that both the inborn and outborn at-risk neonates are transferred or shifted to SNCU for facility-based newborn care for better and further management. Our responsibility, especially with the nurses, during transfer, we should mainly prevent the neonatal hypothermia and prevent delay in transfer to the neonatal care units for prompt initiation of care. Throughout the India, we are having at present 894 SNCU, both in rural and urban areas, to provide facility-based newborn care for better neonatal outcome. So let us now listen from our second speaker, Madam Rekha Sawant, on role of nurses in facility-based newborn care. Madam Rekha Sawant is a senior staff nurse at SNCU KEM Hospital, Mumbai, and she is facility-based newborn care project coordinator, having 32 years experience as neonatal nurse. She did diploma in neonatal nursing course long back, and she is specially trained in kangaroo mother care at Bogota, Colombia, South America, where KMC was first introduced in long back in 1978 by Dr. Edgar Ray and Dr. Martinez. She is the recipient of International Neonatal Nurse Excellent Award at Durban, South Africa. So over to Madam Rekha Sawant for facility-based newborn care role of the nursing personnel.
Good afternoon, everybody. First, I would like to thanks to organizing committee that they have given me this opportunity. We already just heard about the previous topic about the management of neonate in labor room. In this topic, I am going to talk about the role of nurse in main two aspects, role of nurse and role of senior staff nurse. The role of nurse is a wide sector, right from triaging all the ways to basic management to advanced management, which will come in light in subsequent slides. What is the role of nurse and where? Triage, thermal control, feeding and fluid management, management of hypoglycemia, care during respiratory distress, care during seizures, care during phototherapy. Next slide, please. Neonatal sepsis, infection control, documentation and handover, discharge planning and referral, discharge planning, referral. So this is a teamwork. Next slide. This is a teamwork. We nurses and doctors are working together as a team member, resulting the best kind of care to the baby. Next slide. Next. So triage. What is the triage? When the baby comes to SNCU, what will be the first thing we will do? First we will triage the baby, assess the baby to check how sick the baby is. Whenever we are triaging that baby, we are doing rapid screening of the neonates, that which baby required immediate action. And that's why triage is most important whenever a baby comes to SNCU. We triage into 3 groups. That is the emergency treatment, P priority, assessment and rapid action, A non-urgent, assessment and counseling. We have to pick up the emergency signs as early as possible. It is most important. So what are the certain signs that which we are going to see in the next slides? Next slide, please. Hypothermia, apnea or gasping respiration, severe respiratory distress, central cyanosis, shock, coma, convulsion, or encephalopathy. Next slide. So how we will do that assessment and how we will give the emergency treatment? It is a TABC. T, temperature, assess for the hypothermia, deworm the baby. A for airway, manage airway. B for the breathing, not breathing, gasping, severe respiratory distress, apnea or grunting. Then we have to manage airway and start oxygen. Make sure that baby is warm. C, circulation. If CFT is more than 3 seconds, we can fast pulses more than 160 per minute, give oxygen, insert IV line and give fluid bolus 10 ml per kg of the normal saline. Make sure baby is warm. C for coma. Excuse me, previous slide. C for coma and convulsion. If baby is in coma state, so baby will be having CNS problems. If baby is having convulsion, check SGT. If sugar is low, then we have to give 2 ml per kg of 10% glucose. Still convulsing, then we have to give the calcium gluconate 2 ml per kg. Still convulsing, then we have to give the anticonvulsant drugs. Make sure baby is warm. Now D, diarrhea. Look for the for lethargy, sunken eyes, very low skin, pinch. Warm the baby, insert IV line and start fluids rapidly. Next slide. Priority signs: high risk, low birth weight, less than 1,800 grams, cold stress, respiratory distress, irritable, restless, jitteriness, lethargy, refusal of feed, abdominal distension, severe jaundice, pallor, bleeding from any side. Non-urgent signs, jaundice, transitional stools, minor birth trauma, superficial infection, minor malformation. Next time. Next. So when the nurse posted in triage area, so what she has to do? According to the TABC, everything should be ready in triage room. That is for temperature, radiant warmer should be there in proper working condition. Skin probe should be available for that warmer. Then air vent for breathing, oxygen should be there, oxygen central supply or the oxygen cylinder, and humidifier must. For any breathing difficulty, if baby requires ABU bag, so ABU bag with different size of mask with reservoir, laryngoscope, ET tubes, then dextro sticks for monitoring the districts, fluids 5%, 10% glucose, 25% glucose, then normal saline, injection adrenaline, we have to keep. Then miscellaneous, that all the syringes, then drugs, needles, scalpel, scissors, gloves, everything should be ready. And she has to check whenever she comes on duty, it is her duty that she has to check that all the equipments are in working condition. That is the most important thing that we have, nurses have to do. Next slide, please. Thermal control. As we learned earlier that temperature maintaining is the most important thing in newborn care. So maintaining warm room at 26 to 28 degrees centigrade, warm bed, thermoneutral environment is most extremely important in newborn care. In this picture, we can see that baby has kept under radiant warmer, wrapped in the clothes, wearing cap, frock, socks and nappy. That probe has applied on the abdomen of facilitating breastfeeding and KMC. We have to take the temperature with the digital thermometer. Listen, that it is most important thing that whenever there is an alarm, what we nurses are doing, we go and press the button of alarm. Don't do that, because whenever alarm is going on, we have to find out the cause. Why warmer is giving alarm? If probe is displaced from its place, or it is a machine problem. So we have to find out. Next thing, whenever we are keeping under warmer, we have to take the temperature, not chart the display temperature whichever coming on the panel, because it is a machine. Sometimes it may be faulty. That's why we have to take the temperature. Third most important thing is that if the baby is not maintaining temperature, then we have to increase the set point, but it should not be rapid. We have to go step by step. We have to increase towards 0.5 degrees centigrade. Then only baby will maintain the temperature. Next slide. So in this picture, that mothers are helping the baby to maintain the body temperature through the KMC. Next slide. So hypothermia, confirm the diagnosis by recording and body temperature, rewarm the baby as quickly as possible. Mild hypothermia, 35 to 0.5 degrees to 36.5 degrees, 4 degrees centigrade. Remove the wet linen, wrap the baby, provide breastfeeding, KMC, monitor temperature strictly by digital thermometer. Significant hypothermia, less than 35.5 degrees centigrade, remove cold cloth, wear new or warm clothes, cap, frock, nappies and socks, keep under radiant warmer. We have to monitor temperature every 15 to 20 minutes. With that, we have to monitor heart rate, respiratory rate, glucose and CFT. Next slide. So feeding and fluid management, it is very important role of baby care. That is the feeding and fluid management. It depends on how sick the baby is. Whenever we want to give the feed, we have to give according to the baby's birth weight and the day of the life. So at 30 weeks, SSB coordination is not present. So less than 1,200 grams baby, we will give the gavach feeding. At 34 weeks, in between 1200 to 1800 grams baby, we will give the katori spoon feed, and more than 1800 grams, we will give the breastfeeding. For gavage feeding, we have to insert a feeding tube. Whenever we are giving gavage feeding, we have to ensure that the baby's position and the position of the feeding tube. When we are giving gavage feeding, that feeding height should be not too high. That feed will go very fast. Sometimes baby may be having such a desaturation, or maybe baby may go in bradycardia. So now IV fluids, that if the baby is sick, not tolerating feed, then we have to start the IV fluids. This is the chart we use to deliver the volume of the IV fluids to the neonates according to the birth weight and the age of the life. Whenever we start the IV fluids, in this picture, you can see that less than 1,500 gram preterm premature babies, we are giving the more fluid as they are losing the insensible water loss. When we start prepare the fluids, we have to put the label on that syringe, patient's name, then whatever fluid we are giving, concentration, date, time, and rate we have to put on the syringe. Again, whenever we are fixing the cannula, we should remember it should not be very tight or not loose. We have to fix it properly, and we have to use the micropore or the tegadrum, not sticking plaster. We have to observe the IV cannula site properly, that if any redness or any swelling is there, if it is there, then we have to remove. In this picture, we can see the baby is having a swelling. Next is neonatal shock. In essence, certain babies might be sick, so we have to assess the baby. While assessing the babies, if we find that CFT is more than 3 seconds, baby is having cold extremities, then low urine output, jitteriness, low BP, then we have to think that baby may be in the shock. So what we will do, maintain TABC, monitor temperature, heart rate, respiratory rate, and CRT. If CRT is less than 3 seconds, it is normal. If the baby is having hypoxia, we have to start oxygen. If baby is having hypoglycemia, then we have to give 2 ml per kg of 10% glucose. If CFT is more than 3 seconds, then we have to give bolus 10 ml per kg of normal saline. We have to maintain strict intake output chart to monitor for the urine output. In spite of all this, if the baby is not improving, then we have to prepare to deliver the vasopressor drugs, that is injection dopamine, 10 milliequivalent per kg per minute, injection dobutamine, 10 milliequivalent per kg per minute. In spite of normal urine output, we have normal urine output is 1 ml to 4 ml per kg per hour. So in spite of all this, if the baby is having unresponsive shock, then we have to refer to the higher center for further management. Next slide. Hypoglycemia. Hypoglycemia may be asymptomatic hypoglycemia or symptomatic hypoglycemia. We have to keep in mind that asymptomatic hypoglycemia can also cause the brain damage and should be treated promptly. So a sign of the hypoglycemia, lethargy, weak cry, poor suck, temperature instability, poor respiratory reports, apnea, cyanosis, excessive jitteriness, convulsion, or hypotonia. Next slide. In asymptomatic hypoglycemia, if blood sugar is more than 25 milligram per decibel, we will give breastfeed or 20 to 30 ml EBM and check blood sugar glucose after 1 hour. If still less than 45 milligram per decibel, then start GIR. If blood glucose is less than 25 milligram per decibel, give bolus 2 ml of 2 ml per kg of 10% glucose followed by GIR at rate of 6 milligram per kg per minute. Check after 30 seconds and 1 hour. If it is normal, then we have to monitor 6 hourly. Next slide. In symptomatic hypoglycemia, if the baby is having hypoglycemia, then we have to give 2 ml per kg of 10% glucose, dextrose infusing at 6 milligram per kg per minute. If blood sugar is less than 25 milligram per decibel, repeat the bolus and increase GIR. If blood sugar is in between 25 to 45 milligram per decibel, increase GIR by 2 milligram per kg per minute. If still baby is having hypoglycemia, then we can extend at maximum level 12 milligram per kg per minute. In that baby we can give the 7.5%, 12.5%, 15%, or 20 and 25%. Some babies require that they are not maintaining blood sugar. Then listen, if whenever we are giving this concentration, till 15% glucose we can give through the peripheral line. But more than 15% concentration is there, then we have to give through the central line. Continue the infusion until two consecutive values 6 hours apart are more than 45 milligram per decibel. After 24 hours, start tapering GIR by steps of 2 milligram per kg per minute. Next slide. Next slide. Care during respiratory distress. Suppose if we are having a baby of a respiratory distress, then what we will do? So first of all, we have to give proper position to the baby with shoulder roll under the shoulders. Give oxygen through nasal cannula or through oxygen hood to maintain oxygen saturation in between 90 to 94%. Remember that whenever we are giving oxygen, we have to give the warm humidified oxygen. Maintain normal blood temperature in between 36.5 to 37.5 degrees centigrade. If baby needed, then we have to start the intravenous fluid. Maintain blood glucose. Then if still baby is having respiratory distress, then baby required CPAP, that's continuous positive airway pressure. So we have to refer to the higher centers. While during taking care in the respiratory distress, we have to monitor strictly for the respiratory rate and position of the baby. Whenever we are observing the oxygen saturation through pulse oximeter, we have to check that sensor site. If it is discoloration or having erythema, we have to change the sensor site every 2 to 4 hourly. It should not be very tight. So we have to observe that. Next slide. Care during phototherapy. All of us know that all the babies are having physiological jaundice onset of the 24 to 72 hours and maximum at 4th or the 5th day of the life in term babies and 7th day of life in preterm babies. If the bilirubin level is high, then we have to start the phototherapy. Whenever we are starting giving phototherapy, that baby should be as close under the phototherapy. We have to keep the baby, naked baby under phototherapy. Eye should be covered with opaque eye bands. Genitalia should be covered. Maintain the temperature. Then we have to monitor the neurological dysfunction. Strictly, we have to give frequent feeding 2 hourly. Change the position 2 hourly. And we have to monitor the bilirubin level using TCV if available. If TCV is not available, that then we have bilirubinometer. Then we have to send for the lab for checking. After giving phototherapy, again baby is not that the bilirubin level is not coming down. Then we have that baby may require the exchange transfusion, and if facilities are not available, then we have to refer to the higher center. Next slide. So in this picture, we can see that baby kept under warmer under phototherapy, eyes are covered well, and the baby's genitalia is also covered well. Next slide. So now most important thing is that infection control. Whenever we doctor and nurses are working together, that if we not follow the policy of the infection control, so we also can give the infection to the baby. So whenever we enter in hand washing is the simplest and effective method for infection control. It is universal truth that strict hand washing followed by 6 golden rules can prevent the infection. Before entering in NICU, we have to wash the hands for complete 2 minutes, followed by the 6 golden rules. After that, in between 2 patients, if baby is a normal baby, then we can apply only ceruleum. But if the baby is sick or septic infected baby, then we have to wash the hands again for 15 to 20 seconds and take 3 to 5 ml of sterilium on our hands. Now, disinfection policies that no grooming, walls and floor has to clean with hypochlorite solution in 3 shifts. Walls, floors, warmer and trolleys with hypochlorite solution or bacillocid. Weighing machine we have to clean with the hypochlorite solution. For every baby we have to place the fresh autoclave paper. Oxygen wood with soap and water. Sponges, Godadis, frock, cap, KMC bags, everything we have to wash with the soap and water, kept under dry under sun rays and sent for the autoclave. Next slide. Thermometer, then measure tape, stethoscope, should be used separately for each baby. But before using, we have to clean with the spirit. Katori spoon, clean with soap and water and send for autoclave. If facilities are not available for autoclaving, then we have to boil it for 15 to 20 minutes. Use disposable things, 80 tubes, trial tube, needles, suction catheters, then feeding tubes, syringes, everything we have to use the disposable thing. IV fluids, dispose once the bottle is open. Again, for if the babies are getting IV fluids, daily we have to prepare new fluid for the babies. Remaining we have to discard. Whenever we are giving injections or starting the IV fluids, we have to wear the sterile, hand washing has to be done, wear the sterile gloves. Then we have to, before inserting the injection, we have to clean that hub with spirit and then insert the injection or start the IV fluids. Next slide. Next slide. Now, important is documentation and handover. Check for written orders, verbal only in emergency. Once the baby is stabilized, we have to ask the doctor to write on the treatment sheet. Prompt documentation is must. Whatever we are giving, whatever we find in that, everything we have to chart in the intake output chart. Verification of dose with a doctor. If any confusion is there, then we have to ask the doctor and clarify that confusion. Written handover to be given to managing team to avoid any mistake. Important handovers should be reinforced to next team before ending to the shift. Bed by bed, with each baby's paper and intake output chart, we have to give the over and take the over. This is the most important in verbally order over means standing near the table is not correct. Bed by bed, we have to give the over. Whenever we are taking the over, we have to check for the identification tag. If the baby is having IV site, then we have to check the IV site also. If the redness or swelling some is there, we have to check the infusion pump, that whatever fluid has to go, it has gone or not, it is working or not. Everything we have to see. Next slide. Next slide. Discharge and planning. So we have to keep in mind that whenever we are planning the discharge, check for the weight gain for 3 consecutive days. Baby should not be ill. Baby should not be on the antibiotics. Only on the nutritional support. We have to give, baby should be taken taking only breastfeeding or the katori spoon feeding, no gavach feeding. Then baby is maintaining temperature in KMC or in wrapping the baby. And most important, that nurse has confidence that mother can take care of the baby, and mother is having confidence that I will take care of my baby. Then only we can discharge. We can think about the discharge planning. Whenever we are giving discharge, we have to call the mother, father, and the close family members, that grandparents, mother-in-law, everybody, and we have to explain each and everything in their mother tongue. So at that time we have to explain about the previous slide. So we have to explain about the breastfeeding. 2 to 3 hours she has to feed the baby, especially at the night time. Again, she has to give bath a more than 2.5 kg baby, less than 2.5 kg baby. Only sponges she has to do. Again, breastfeeding. Then how to keep the baby warm, frock, caps, socks, and wrap the baby very well, especially in winter season. Then importance about the vaccination and danger sign. Mother is a good observer. She can make out any changes in baby. So she has to come to hospital as early as possible. Advice regarding follow-up. Whenever doctors call for the follow-up, she has to come for the follow-up. Next slide. Referral. Any neonate who has need for mechanical ventilation, unresponsive shock, jaundice needing exchange transfusion, refractory seizures, refractory hypoglycemia, need for the surgical intervention. Next slide. Next slide. Next slide. Referral counseling will be come in next lecture, so I am not going in detail. Ensure presence of required equipment during transport and accompany during transport, and regularly assess vital parameters during and temperature check during transport. Next slide. Administrative role of senior nurse. Inspection control practices. Ensure protocols are followed. Indent and stock keeping, equipment management, human resources management, teaching and support supervision of the nurses. Next slide. Conclusion. Nurses play a vital role in sick newborn care. Refresher training with case scenario drills and constant mentoring required time to time. FBNC training package and its nodule serves as a ready reckoner for the comprehensive nursing care of sick neonates. Sequential steps of nursing process during nursing care helps the nurses to provide the care in a competent manner. Thank you.
So thanks a lot to Madam Rekha Sawant. She has discussed briefly about the huge content of facility-based newborn care with the important aspect, especially on triaging of sick neonate and special care required for the neonatal problems in hypothermia, shock, hypoglycemia, respiratory distress, phototherapy, prevention of infection, documentation, discharge planning, etc. We all know that treatment of sick neonates, there is FBNC standard guideline. It's a huge content. We used to give training for 4+14 days. And so those who have already trained, they know there is details information are there. You can go through of that. So these are the briefs just to highlight and motivate yourselves to do better in your in this newborn week, to do better in your places. So what we have to do now, we have to implement the standard guideline with the special emphasis, especially by assessment, identification of the neonatal problem as early as possible for prompt initiation of the management, and then monitoring. It is the most important nursing responsibility, monitoring of the sick neonates and preterm lower birth, all the neonates admitted in the facility. So monitoring is our very important responsibility, and along with the prevention of complications. If we are doing the monitoring and continuous observation and continuous caring in scheduled time, then there will be less complications. So it is our most important responsibility. Prevention of infection is another important, along with meticulous hand hygiene, aseptic precautions during invasive procedure, prevention of medication error, bedside handover takeover, and mother's involvement during care is most important nursing responsibility. I think we all are doing these things, but we have to again take commitments from this presentation that we will do more better. So we know the majority of the neonatal beds in SNCU for facility-based newborn care are occupied by preterm low birth weight neonates due to various reasons. So let us listen from our third speaker, Madam Siba Piyush, on role of nurses for care of preterm neonates. Madam Siba Piyush is nursing officer at neonatology department, Dr. RML Hospitals, New Delhi. She did MSc Nursing in Critical Care from RK College of Nursing, Delhi University, and she also did Diploma in Health and Hospital Management from IGNOU. Over to Madam Siba Piyush for care of preterm neonates.
Next, please. A very good afternoon to all the dignitaries, panelists, and participants. I thank all the organizing committee members for giving me this opportunity to speak on this platform. Till now, we have seen the role of nurses in preparation of labor room,
care of newborn at birth, and the care of a sick neonate in NICU. Now, let us talk about the care of preterm baby. Next. The preterm is defined as a baby born alive before 37 completed weeks of gestation. In India, 27 million babies are born every year. In that, 3.5 million are born prematurely. Next, please. According to the gestational age, the preterms are classified as extremely preterm, who are less than 28 weeks of gestation. Between 28 to 32 weeks, they are very preterm, 36 weeks, late preterm. Next, please. Due to the physiological immaturity and organs, the preterm is predisposed to various challenges, such as fragile brain capillaries leading them to intraventricular hemorrhage, immature lungs leading them to develop respiratory distress or apnea, and weak immune system predisposing them to infections. Next, please. Though it has been discussed by Madam Rekha regarding hypothermia, I just want to reinforce that hypothermia is classified in three categories, that is mild or cold stress, that is between 36 to 36.5 degrees centigrade, in which is characterized by hands and feet are cold and abdomen is warm. In moderate hypothermia, the temperature varies between 32 to 35.9 degrees Celsius, in which the hands, feet, as well as the abdomen are cold. And less than 32 degrees centigrade is the severe hypothermia. Next, please. We as nurses can take measures to prevent hypothermia in various stages, starting from the delivery room, maintaining the temperature at 26 to 28 degrees centigrade, receiving the baby in warm towel and ensuring skin-to-skin contact and initiating early breastfeeding. While transportation, ensure to transport in a warm incubator. If it is not available, transport with mother, ensuring skin-to-skin contact. While in the postnatal ward, ensure rooming in, keep the baby with the mother, ensuring skin-to-skin contact and breastfeeding. And while discharge, educate the mother to continue KMC and continue exclusive breastfeeding at home. Next, please. The next challenge faced by the preterm baby are apnea and respiratory distress. In apnea, stimulate the baby once or twice. If not, if it is respiratory distress, which are characterized by rapid labored breathing, indrawing of the chest, nasal flaring, grunting, then start CPAP. So the key message for apnea, start positive pressure ventilation, and for respiratory distress, start CPAP. Next, please. Respiratory distress is monitored by checking the respiratory rate, oxygen saturation, and respiratory distress monitoring by the Silverman-Anderson score in preterm. Next, please. In Silverman-Anderson score, we assess the upper chest retractions. If it is equal, we give a score of 0. And if it is respiratory lag, then score 1. And if it is a seesaw respiration, then score 2 is given. If it is lower chest retraction, if no lower chest retraction, it is 0. If it is minimal, then score 1, and marked retractions are there, then it is score 2. Deferred retraction, if it is present, if there is no retraction, then 0. If it is minimal, then 1. And if it is marked, we give the score of 2. If no nasal flaring, then the score of 0 is given. and if it is 1, then minimal and mark is given score 2. Expiratory gun, if there is no grunt, then score 0 is given, and if it is audible with the stethoscope, then 1, and if it is audible, then it's given 2. So after totaling, if the score is 1 to 3, we consider it as mild RD and the baby may need mild oxygen support with the oxygen cannula. And if it is between 4 to 6, it is moderate respiratory distress and needs CPAP. And if the score is between 7 to 10, it is considered as severe respiratory distress and the baby needs ventilation. Next, please. So monitoring respiratory distress is the key to management of respiratory problem. Always maintain the saturation between 90 to 94%. Next, please. Fragile brain capillaries predisposes them to develop intraventricular hemorrhage. We as nurses can prevent IVH by providing gentle and minimal handling, administering IV fluids and drugs slowly by the usage of syringe pump, avoid rapid IV pushes and boluses, avoid unnecessary suctioning, gentle daily routine care and gentle support. The key message to prevent IVH is gentle in care. Next, please. Due to poor reflexes and inability to coordinate, suck and swallow and respiration, preterm baby faces feeding problems. Alternate ways of feeding has to be initiated to ensure nutritional supplement, such as orogastric feeding, Katori pallida feeding. Early enteral feeding promotes gut motility and prevents NEC. Non-nutritive sucking can initiate the feeding cues. Next, please. Due to weak immune system, the preterm is prone to get various infections. This can be prevented by various good practices, such as proper hand washing, following the 5 moments of hand washing, minimal handling, early enteral feeding, having good housekeeping and infection control policies in place. The next, please. The 5 moments of hand washing has been discussed by Madam Rekha. Next, please. Due to the immaturity of liver, the baby is prone to develop jaundice. It can be prevented by monitoring skin and sclera or with covered breastfeeding and monitor temperature and urine output while the baby is in phototherapy. Next, please. The other problem faced by the newborn is hypoglycemia. It has been discussed in detail by Madam Rekha. Next, please. Immature retina is susceptible to oxidant damage. ROP screening to be done to all babies with birth weight to less than 2.5 kg and all babies less than 34 weeks. And the babies between 34 to 36 weeks with any risk factors, such as sepsis, on long-term oxygen therapy or on with the IVH. When to screen? The baby has to be screened at 4 weeks of age, and if it is preterm less than 28 weeks, then between 2 to 3 weeks. Next, please. To prevent ROP, meticulously monitor oxygen levels. At no time, the saturation should be more than 94%, and timely screening is very important. The key message to prevent ROP is timely screening and targeted oxygen saturation between 90 to 94%. Next slide, please. Other problems of prematurity, such as anemia and osteopenia, can be treated by anemia can be prevented by delayed cord clamping at birth, minimal sampling, monitoring the hemoglobin levels, iron prophylaxis to be started at 4 weeks of age. Osteopenia can be prevented by the nutritional supplementation on the, such as calcium, phosphorus, and vitamin D3. Next, please. So, no, the previous one, please. So, we have seen the various problems faced by the preterm baby, and they are in our hands now for their healthy survival. Developmentally supportive care is the best approach for preterm care because, next please, because the most rapid brain growth occurs immediately before and after 40 weeks of gestation. So they are in this vulnerable stage, and we are aiming to provide a similar atmosphere as that of utero, where there is minimal light, noise, and less disturbances. Next, please. Next, please. Which reduces stress and promotes growth and weight gain. So developmentally supportive care is the best approach for taking care of the preterm baby. Next, please. The 5 core components of developmentally supportive care are family-centered care, protected sleep, pain and stress management, healing environment, developmental activities of daily living. Next, please. FCC, that is family-centered care, is the core of developmentally supportive care, aiming to partner parents in the care of their neonate. Often, the mothers come in contact with the nurses, and we play a major role in FCC, partnering the parents in the care, reassuring them to gain confidence, be compassionate with the mother, and demonstrate them essential caregiving skills, and thus empower them so that they are confident enough to take care of their neonate. Next, please. In this picture, we can see assisting the mother for breastfeeding. Previous one, please. And transforming the mother to the role of a primary care provider. So the mother is empowered to take care of their neonate by partnering in the care of the baby, such as cleaning the soiled baby, breastfeeding, expression of breast milk, pallida catora feeding. So the other component of DSC is pain and stress management. Next, please. Some of the signs of stress are characterized as facial grimace, crying, saluting, and finger splashing. Next, please. The pain can be managed by breastfeeding and containment while sampling. Next, please. Next, please. The best practices to provide a healing environment in NICU are by providing a calm and quiet atmosphere, such as by keeping our mobiles on silent mode, keeping the machine's alarms on low mode, staff discussions to be in the low volume, ringing of the telephone to be minimized, avoiding dropping of balls and dragging of chairs, adjusting the light to minimum so that in dim light, arranging dimming of light in the night, and use of overhead lights for any procedures, and while putting it on, cover the eyes if possible. Avoid toxic perfumes by the staff and the care providers. Keep the hand rubs away from the baby. And no noxious disinfectants and skin care has to be taken care. Check pulse oximeter probe and use baby-friendly adhesive. The other basic preterm care includes nesting, oiling, cling wrap application, minimal handling, cluster of care, skin care, and do no harm. Next, please. Nature cares its preterm. Adapting the principle from kangaroo The concept of kangaroo mother care has evolved in the care of preterm. Next, please. The key features of kangaroo mother care are skin-to-skin contact, exclusive breastfeeding, early discharge, and follow-up. Next, please. Whom to give? All stable babies, preterm babies eligible for KMC. When to give? When the baby is hemodynamically stable. And how long we have to continue the KMC? Till the baby's weight is more than 2.5 kg. Next, please. KMC is the best developmentally supportive care. In this position, the baby is in close contact with the mother, which stimulates all the neonatal senses of the baby. By the touch of the baby, by the sound and heartbeats of the baby, by smell and taste of the breast milk, baby gets the stimulation of its senses. Next, please. What are the benefits of KMC? KMC is beneficial to the baby, parent, family, and to the nation. It facilitates physiological stability, reduces apnea, prevents hypothermia, stimulates neonatal senses, improves bonding. It is cost-effective and reduces morbidity and mortality rate. Thus, it is beneficial to the baby, to the parent, family, and to the nation. Next, please. Nurses play a vital role in the care of preterm. She takes the role of an advisor, counselor, care provider, demonstrator, and health educator, and many more. Always keep an account or record of all our activities, what you have done, whether we have counseled, what education we have done, and all the treatment and cares, whatever we have done, we as nurses have to keep a record of it. So, till now, we have seen the involvement of developmentally supportive care, family-centered care, kangaroo mother care in the care of preterm, and the baby has developed and ready to discharge, and what we have to do at the time of discharge. So growth monitoring. Ensure before the discharge, the baby is screened for hearing, thyroid screening, and follow for early detection and early intervention. Nutritional supplements has to be given, such as iron, calcium, and vitamin D3. Counsel for feeding, exclusive breastfeeding has to be counseled. Continue camps, kangaroo mother care. All this counseling has to be done at the time of discharge. So all through our care, the baby was with us in the NICU. We have empowered the mother to take care of the baby even at home, so that the care, continuum of care is maintained in the NICU and at home by empowering the parents. So it is all in one, all together. Care of preterm, it is in the kangaroo mother care, family-centered care. It is embedded in the developmentally physical development of the baby and making the baby a healthier person. We take care of them today and they will take care of our tomorrow. Next, please.
So thank you, Madam Siba Piyush. Think last slide. Thank you, Madam Siba Piyush. You have nicely highlighted about the care of preterm neonates, especially on developmental supportive care, special care for the preterm problems, good nursing practices for feeding, infection control, kangaroo mother care, family-centered care, ROP and hearing screening, and follow-up care. So we know the prematurity is the leading cause of neonatal mortality. If we have to achieve the INAP target, so we have to take care of the preterm neonates in a different way, and more quality improvements should be done for that. Just 17th November, we have the prematurity day. So there is so much of commitment. So we have to follow that commitment, and we have to provide care to the preterm baby according to the standard guideline. Number of preterm births are increasing due to lifestyle changes. So more emphasis should be given to improve the quality of preterm neonates, quality of care for preterm neonates to prevent deaths and long-term complications. Just simple measures, nurses has to practice more about use of antenatal corticosteroid, kangaroo mother care, feeding with mother's own milk, that is mom, and developmental supportive care along with the family participation, early intervention and stimulation to prevent preterm long-term complications and hygienic practices. So we should motivate ourselves to provide skill and competent care of these sick preterm and low birth weight neonates to revive, to survive, and to thrive as a future citizen. So let us listen from our fourth and last speaker of this session, Mr. Chenaram Prajapat, on effective counseling care of newborn. Mr. Chenaram is nursing tutor from School of Nursing, Barmer, Rajasthan. He is the state trainer of ASA Module 6 and 7. He is district trainer for training of SBA, NSSK, IMNCIs, HBNC, IYCF, HBYC, RBSK, PPICD, and LUX program. Over to Chenaram for effective counseling care for newborn.
Good afternoon, everyone. I would like thanks to Dr. Manohar Agnani, Additional Secretary, Dr. Sumita Ghosh, Additional Commissioner, Dr. Rati Balachandran, ADG Nursing, Dr. Kapil Joshi, Senior Consultant Child Health, all panelists, all participants, and my colleagues. Our previous speakers told about the nursing care of the newborn. As we know, with the nursing care, counseling is an also very important part for the care of the newborns. Then what is the counseling? Next slide, please. Next, please. What is counseling? Counseling for the maternal and newborn health is an interactive process between the health worker, women, and the family, during which information is exchanged and support is provided so that the woman and her family can make decisions, design a plan, and take actions to improve their health. Now the question, we already know what is the counseling, but how to counsel is the very important. And what is the requirement for the counseling? For the counseling, our communication skills are very necessary. And we are intelligent, we know everything, but how to counsel, how to communicate the message by the communication skills is very important. जब हमें कम्युनिकेशन स्किल्स का अच्छे से जान लेंगे तो हम जितना जो देना चाह रहे हैं, जो समझाना चाह रहे हैं, वो अच्छे से हम उसको डिलीवर कर पाएंगे. नेक्स्ट स्लाइड प्लीज. When we want to counsel someone, then we use some principle of counseling. First is the use care, the technique or the Galpek technique. Galpek G means greeting. Greeting mother with the hello, hi or the namaste. Then asking the question, opponent questions. Then listening what the mother is saying. It's very important to listen what the mother is saying. Then praising what the mother doing good things for praise for this. And then advising the mother and check that mother understood well or not. Then talk with the pleasant voice and the appearance, and then use some non-verbal communication technique also very useful, as like the keep the head level equal, then keep appropriate distance, they pay attention what the mother is saying, remove the barriers. Means when we communicating the mother, we don't use mobiles, we don't write on the papers or the files, and then touch appropriately whenever and wherever required, and then taking sufficient time. Means don't show any type of the hurry when we're talking to the mother. Next, please. Then use the responses and gesture which shows interest. Reflect back what the mother or the parent says. Empathetic way. What is the empathy? Empathy means I am feeling your problem, not understanding. I am feeling your problem. मैं आपकी प्रॉब्लम को महसूस कर रहा हूँ और उसके अकॉर्डिंग आपको अपने इमोशंस भी हैं उसके अकॉर्डिंग चेंज करने हैं. Then use the simple language. We talk to the mother tongue or the local language. We don't use the medical terms. Then give practical help whenever and wherever required. Maintain emotional stability. Whatever the condition is serious or the normal, we keep ourselves calm and emotionally stable. And then two-way communication is very important. And with this help, mother to ask their questions and queries and resolve the mother's clarify their doubts. And then counseling must be individual need based. हमेशा ये ध्यान में रखना होगा कि काउंसलिंग जो होती है वो सभी के लिए एक जैसे नहीं हो सकती. इट्स डिफरेंट फॉर द डिफरेंट प्रॉब्लम्स एंड इट्स अ टेलर मेड. लाइक ए सर्ट जो अपना डिफरेंट व्यक्ति के लिए जो डिफरेंट सर्ट आता है, उसी तरह से हर एक की काउंसलिंग भी डिफरेंट रहेगी. एंड इन द वन लाइन आई कैन से काउंसलिंग शुड बी स्मॉल एंड फ्रीक्वेंट फीड. लाइक जिस तरह से हम भोजन एक साथ बहुत ज्यादा डाइजेस्ट नहीं कर पाते, उसी तरह से काउंसलिंग भी एक साथ बहुत सारी नीड रहनी चाहिए. It should be small and frequently should be given according to the need of the a person. Next one. Next, please. Here is the counseling process. I've already discussed about the counseling principles and the guiding skills. Next, please. Again, here's the guiding principle and the counseling skills both interact each other and lead to a good counseling, effective counseling process. Next, please. Counseling area. For the maternal and newborn health, where we counsel in the labor room, in ICU, in the referral of the newborn, in the condition of the newborn death, in the postnatal area, or at the time of the discharge, we counsel the mother and the attendants for the newborn health. Next, please. Counseling in the labor room. As we know, the first impression is the last impression. So when the mother comes into the labor room, we receive the mother with a smiling face and give a warm welcome and reassure her that the things are going well. And keep in mind a respectful maternity care is very important. Ensure the privacy and dignity and the confidentiality of the mother. Ensure freedom from any type of the mistreatment or the harm. Ensure the informed consent and respect to the right to the refusal, and ensure the freedom from any type of the discrimination. Next, please. In the labor room, allow the birth companion of her choice is important. And the birth companion and the nurses help to mother to relieve the pain and stress by the non-pharmacological management, as like the massaging her back, holding her hand, or sponging her face in between the contraction, and the talking with the gentle or the soothe and calm voice. These all things help the mother to relieve from the stress and build up the confidence, and tell the mother that she is there for your care, and praise the woman. And after the birth of the baby, if birth cries well and the baby is normal, then give the baby to the mother, hand it over the baby to the mother, and start the immediate breastfeeding. And now here counsel for the immediate initiation of the importance. What is the importance of the immediate initiation of the breastfeeding, and what is the importance of the breastfeeding. And the next, please. Here we can see a staff nurse counseling a mother in the labor room. Next, please. Counseling in the SNCU. If baby not cries well or baby is suffering from the birth asphyxia, that time inform the mother. Important thing, inform the mother that your baby not cried at this time and we are shifting baby into SNCU for the treatment. It's very important information to the mother. And then explain the condition of the baby or to the parents or attendants in the local language, in the simple terms. And in the SNCU, encourage the family participatory care is very important. If family member present with the baby in the SNCU, then it help to reduce the stress of the family member, also help into the care of the baby. And then they also having the chance to learn how to care the baby at the home. And then keep the empathetic attitude and the supportive attitude towards the care, entire the care. And this should be reflected in our voice, tone, eye contact, and attitude. And then respect the families, the culture and the socio-economic background, and give sufficient time to the mother and build a rapport with the mother. And what things happen normally in the SNCU, we forget to the mother in the SNCU and just focus on the baby. So here is need to be care of the mother is also very important, and talk to the mother, build a rapport with the mother, and help the practical help whenever and wherever required for the baby. Next, please. And then in the SNCU, FPC session counseling is also important, and session counseling should be maybe in the group or maybe in the individual as the need based. And it's the collective responsibility of all we nurses in the SNCU to counsel the attendants, and this help into the build up the confidence of the parents in the care of the baby, and they feel the more relaxed, and ensure the attendant that we are providing the quality care for your baby. Next, please. Here you can see the family participatory care, mother sitting with the baby in the SNCU. Next, please. Then explain the at the time of the referral of the newborn, if there is need of the referral of the baby, then explain the cause of the referral, what are the treatment we are giving here, and what are the treatment or your baby require. And then after the consent and counseling of the attendants, we only can refer to the baby to the higher center. And here is the practical help is important, as like the collecting the investigation reports and the preparing of the referral card and the arranging of the ambulance facilities, shifting to the baby into the ambulance and attach the all appliances and giving the medications to the baby. These all things are very important. Practical help is here is very important. Next, please. Here clarify all the doubts of the attendants, and then information to the next facility is the very important. And then tell the attendants that we had already informed to the next facility, and then name the concerning person who will attend there. Next, please. Counseling in the case of the newborn death. It is one of the hardest thing to communicate parents that their baby is no more. So explain the seriousness previous to the death, so the attendants mentally prepare for this type of incidents, and allow the attendant to visit the baby and explain the condition regularly. And one of the important thing here, then as early as possible after the declaration of the death, inform the attendants. Next, please. And this information should be in the private area, if possible in the private room or in the confidential area. And here we inform, here we explain the cause of the death in simple terms and the efforts made by our health team, and just to put our hand on the shoulder and says that we had done our best effort and the God is the director and we are just actor. कुछ चीजें हमारे कंट्रोल में नहीं होती, अपने हाथ में नहीं होती है, हमने हमारा पूरा प्रयास किया था, फिर भी हम चीज उसको सर्वाइव नहीं कर पाए, इसके लिए हम कुछ नहीं कर पाते क्योंकि हम कुछ चीजें भगवान के हाथ में होती है. नेक्स्ट प्लीज. Allow the attendants to spend time with the disease, which help in opportunity in the relatives to say that goodbye, looking peaceful as a last memory, confirm death and make it real, opportunity to hold or embrace a diseased person, provide a sense of closure. Next, please. Provided here again practical help, as they provide the certificate of death and inform that from where you can get the dead body as per hospital protocol, and keep in mind the empathetic attitude, and according to the situation our emotions should be like that. Next, please. Counseling in the postnatal ward. In the postnatal ward, counseling 3 or more important things are: first, the importance of the colostrum feeding. Tell the mother and ask the mother what's the importance of the colostrum feeding and the importance of the breastfeeding, exclusive breastfeeding, and then give practical help into establishing the position of the baby for the breastfeeding, and how to cover the baby well, and they give sufficient time to the mother to ask their questions and clarify doubts, and counsel regarding the myths of the breastfeeding, and remove all the myths, and counsel for the vaccination and its importance. Next, please. Counseling at the time of discharge. Before discharge, we also inform about the discharge planning when we are going to discharge, so the attendants prepare themselves for the discharge. And after then, counseling at the time of discharge with the help of the MCP card is very important, because the MCP card is a tool which contain all type of the information regarding the newborn care. So we use the MCP card as the counseling tool. Actually, it's unfortunately it's our drawback. We are not using, many of us not using the MCP card as the counseling tool. So keep in mind, we use the MCP card while we counsel the mother regarding the newborn care at that time of the discharge, and we counsel on the following areas: exclusive breastfeeding, keep the baby warm and the postponed bathing, cord care, immunization and schedule, importance of the immunization, hand washing techniques, prevention of infection, precaution from COVID-19, and then next, please. Here you can see the pictures of the baby attachment on the mother's breast. Then next, please. Here you can see the hand washing technique in the 6th step with the soap and water. Next, please. Kangaroo mother care and importance of the kangaroo mother care. Next, please. Then counseling on the avoid the harmful practices, as like the balding of the hair, or putting oil in the nostrils, or the application of the kajal in the eyes, or application of cow dung on the cord. These all things cause the infection in the baby, so these things should be avoided. And the special counseling regarding the preterm or the LPW babies and the sick babies, and the counseling for the maternal health, such as the extra meal and the calcium and IFS supplementation, and the family planning counseling, and allow the mother to choose the method of the family planning, importance of the birth registration, and the preservation of the important document as like the birth certificate, MCP card for the future reference. Next, please. And then here again, the mother having attention that here is a doctor and nurses are here for the care of the baby. And then when they go to home, then who will there? Then inform the mother that the ANM, ASA, CHO will visit to your home to the care of the baby according to the HBNC schedule. And the baby who is discharged from the SNCU, their first day counted from the day of the discharge, and the next visit accordingly. And they give emergency contact number for their so that they can call in emergency conditions, and then advice for the follow-up. And so then the importance of the follow-up visit, because the SNCU discharged baby having the more chances of morbidity and the mortality, 8 to 10 times more chances than the normal babies. And then counseling regarding the growth and development. Next, please. And then danger sign. Danger sign, elaborate the danger sign as like the poor feeding, excessive crying, undue lethargy, respiratory difficulty, sudden rise or the fall in the body temperature. Next, please. Diarrhea, vomiting, convulsion, bleeding from the any side, appearance of the jaundice. If any danger sign is present, contact with the nearby health facility. And at last we check. हमें check करना होगा कि जो हमने कुछ बताया है वो मदर ने सारा कुछ समझ लिया या नहीं. एट लास्ट मैं ये मैसेज देना चाहूंगा कि काउंसलिंग के लिए हम खुद मेंटली और फिजिकली प्रिपेयर हों. काउंसलिंग शुड बी नीड बेस्ड. काउंसलिंग लाइक द स्मॉल एंड फ्रीक्वेंट फीडिंग एंड अंडरस्टैंडिंग द इमोशंस आल्सो वेरी इंपॉर्टेंट. एंड एट लास्ट हम ये श्योर कर लें कि हमने जो बताया है वो उसने सारा समझ लिया या नहीं. अगर नहीं समझ पाए तो रिपीट द थिंग्स अगेन. थैंक you very much.
Thank you, Mr. Chenaram. You have talked about the process and principles of counseling, including different aspects and situations of counseling for neonatal care. We all know that counseling is the backbone of continued care at home for the sick and preterm and low birth weight neonates for their better survival. So what we have to do, we can do the individual counseling, we can do the group counseling for the mothers along with the family members, both in the facility and in the community. Hope this interaction will help the mother to become confident to take care of her small baby with the family support, to provide optimal and best continued care at home, along with the support of facility-based follow-up care from the facility for the better survival of the sick and low birth weight preterm neonates. We have to do counseling in the facility, in the labor room, postnatal ward, SNCU, and during discharge. In thorough counseling should be done, and also at the home by the community health worker. And based on the level of understanding of the mother and the family members, we can just give the information, and we have to check the understanding of the mother and family members. Then it will be effective counseling. We have to do the effective counseling. So we have to work hard together with all team members and the family members for the preterm, low birth weight and sick neonate, as that will be the caring for the future, our future generation and our future citizen. And we have to provide comprehensive neonatal care as a preventive, promotive, curative, and rehabilitative care. So thanks a lot to all speakers, participants, and organizers. Now I am concluding this session with the expectation that with the nurses working for the neonates, our future generation, we have to work hard, skillfully, with positive attitude and updated knowledge to improve the quality, equity, and dignity of the newborn at all levels of care. Now I am requesting my team leader, Dr. Kapil Joshi, to anchor sharing of experience by the state. Thank you, everybody. Over to Dr. Kapil Joshi.
Thank you, Dr. Parul Datta. Before moving to the next session, I would like to request Additional Commissioner Madam Sumita Ghosh to share us the guiding words on these technical sessions. Madam, please.
Thank you. The sessions were excellent, and it covered each and every respect of newborn care, looking through the prism of every angles have been covered. So I thank Mrs. Jasipal, Mrs. Rekha Sawant, Mrs. Shiva Pyas, and Mr. Chaina Ram Prajapat for the excellent presentations made and the way it was discussed. I do hope all the participants, I believe some thousands of them who have joined, they have gained a lot from this. The presentations will be shared, so it will make a sea change in the practice of what we do in our facilities. I have to leave for some urgent work. Tomorrow is the big day for us because Honorable HFM is going to launch our books and all. So for that I would like to take request you to give me leave. The way forward, I would like to summarize is in improving the knowledge and the skill. 8,264 registrations were there, and 3,000 joined us on Zoom and YouTube 290. So it's a big participation. I do believe this four presentations made on every aspect of neonatal health and care, they have been will be very beneficial. So way forward is to improve our skills and knowledges, because as I already said, the target is quite ambitious to bring our neonatal mortality down to single digit by 2030. So that's a big task. So I would request that since we have facilities or network of facilities at public health facilities all over the country now, the quality issues should be looked at. There should be the true leadership at the facility. The guidelines, protocols already are there, so they need to be followed. Each center should develop as a model of care, taking into account every aspect of our practices, clinical practices, as well other as per the SOPs and protocols. We should encourage the participation of the mothers and the family members, because that is another aspect of quality that improves the experience of the people. The capacity building efforts are on, and all the training modules which are being released, they should be read properly by our staff and healthcare providers to give the proper quality about this is a big role. We should give proper informations to all, and we should encourage collaboration among all the stakeholders. So these are the few steps for improving the quality, and I would request all who are present here and working at every nook and corner of the country to take forward this agenda of quality and improved clinical skills and practices in our public facilities, so people start trusting our public facilities, and we are able to give them the proper care. Thank you very much. This session will go on. I will not be there, and I request that because it is online training, everyone takes things seriously, and they attentively hear what is being said. Thank you very much.
Thank you, madam, for your guiding words. For all of us, we all can say that we will do the needful as per your directions and as per your guidance. We will definitely achieve the single digit NMR as per the Government of India Sustainable Development Goals, also as per the INEP goals also. Now we will move to the next session, which is a peer learning kind of session. This is an experience sharing session. So in this regard, first of all, I would like to request Mr. Manish Tiwari, who is a nursing officer from the Chittorgarh SNCU, Rajasthan. And we want to hear from him that why, since last many of the months, her SNCU is a #1 in Rajasthan. What all the teamwork, what they are doing, which results in the success. So may I request Mr. Manish Tiwari to kindly share the success.
Good afternoon, all. And Thanks, Additional Doctor Sir and Additional Commissioner Madam and all the writer team for giving me this opportunity. Monthly data analysis is done by the state government for ranking the units, and it is in which the unit is ranked at the top. Essentially, Chittorgarh has been awarded as the best unit of the Rajasthan consecutively last since 4 years. The unit follows all the standard protocols of SNSU provided by Government of India. Here, RDS, prematurity, infection, lower fat, and severe berthopsia are the commonest cause of neonatal mortality. To reduce the mortality from these causes, we are continuously working and improving the causes to get better results. Here, baby and disease-specific care is provided to every neonate, for which every month we are organizing a meeting of all staff of SNSU with MoIC to analyze and discuss the progress of the unit and mortality audit. New ideas for the better functioning and development of the unit from any of the team member is welcomed and discussed. The best worker of our SNSU is awarded by certificate by MoIC. Every newborn is nursed in a safe and thermometrical and comfortable environment like temperature, sound, and light, with the use of nesting, KMC, and maternal approach. Family participatory care, providing trainings for family participatory care and supporting breastfeeding and KMC by staff, preferably female staff, is a regular feature of this unit. He maintains different checklists for nursing staff, Yashoda, and assisting staff. Housekeeping and hygiene is maintained routinely in every shift as per protocol. All members of SNSU team, MIC, nursing in charge, nursing staff, support staff, and guards all follow SNSU protocols, whether it is hand washing, routine cleaning, monitoring, treatment, feeding, and all other with Government of India protocols. Here, special care is taken to keep newborn clean and infection free. Playing light and soothing instrumental music. The ambience of the unit is maintained soothing and comfortable by playing light and soothing instrumental music, which adds an early recovery, quick sleep, and cognitive development of the neonate. We use the sound meter and level lux meter. The babies are nursed in appropriate light by the use of sound meter and lux meter. Monitoring of humidity, temperature, light, and sound, and maintaining all these data in log sheet is a routine process of our unit. Our unit have every radiant permit is provided with a separate accessory, so that the equipment is shared among the babies to reduce the infection rate. Discussing during unit rounds to develop the skills and capacity building of the staff is a regular feature of this unit. A customized stationery rack has been developed to keep all the stationeries of SNSU in different racks to reduce the wastage of time in searching of particular stationery. And our dedicated DEO, Yamini, maintains all data like admission, discharge, referral, outcome, and tracking and facility, as well as community follow-up up to date in data and SNSU online software. And this success of our SNSU lies with the dedicated and devoted team under the able leadership of our MOIC, Dr. Jaisingh, who continuously motivates us and guides us. Thank you.
Thank you, Mr. Manish, for all these words, that your facility is following all the guiding principles and the SOPs which is given by the Government of India. And by following all these guiding principles, you are achieving the success. So it's nice to hear from Rajasthan. Now we will move to Madhya Pradesh. I would like to request Bharti Gehlot. She is a staff nurse from Ratlam district, Hospital, SNCU, Madhya Pradesh. I would like to request Bharti Gehlot to kindly share her experience. Bharti
Thank you,
Gehlot.
sir. Good evening, all the senior faculties, all the senior nursing staff, and my colleagues. My name is Bharti Gehlot. I'm working as an in charge of SNCU at District Hospital, Ratlam, Madhya Pradesh. First of all, I'm really glad and feeling honored to be a part of this campaign, and it's my privilege to share some of the good practices of my unit. And I hope that sharing such experiences will bring a positive change in providing quality care to a sick and delicate newborn. In essence, our aim is just not to treat and save the life of the neonate, but we also focus on the intact survival, appropriate growth and development of the baby, especially the neuro development. Because a healthy survival of a baby will constitute a healthy society also. We all know that the baby who are discharged from SNCU may develop some neurodevelopmental issues also. So it is quite important to diagnose such issue timely for better neurodevelopmental outcomes. To address such things, we have a follow-up OPD as well as a neurodevelopmental assessment clinic also. It is a part of our SNCU care. We follow up our SNCU discharge baby as per the schedule. We have a dedicated nursing staff for neurodevelopmental assessment clinic who interacts with the mother and other close relative of the baby. And she tries to find out the growth and developmental issues with the help of the tools and growth charts which are provided. At the same time, she used to record the anthropometry of the baby to find out the lag between the actual and the expected growth. After documenting initial details and growth parameter, baby reviewed by the SNCU doctor where he advises and manage accordingly. Once the baby is identified with neurodevelopmental issue, then in coordination with RBSK coordinator, we send these baby to a DIC center for further management. Some of the discharged baby who are unable to come for follow-up on given that our nursing staff telephonically follow up these babies and ask about the feeding habits and the developmental milestone as per the age, and also counsel about the danger signs of to be watched for their babies. And we also encourage them to come for timely follow-up and immunization as per the schedule. Hence, from above practices, we are trying to get our essence to discharge baby from the survival to a healthy and the intact survival. Apart from this, I would like to share that in our state, all the delivery point nursing staffs are doing the comprehensive newborn screening also. And it is the essential part of our newborn care services. We have started a pilot project in our district that one nursing staff from SNCU visits all the delivery point at least twice in a year for supportive supervision and give the hand-holding training also. So hopefully this will be helpful for many of us in providing the good and productive care in the newborn in day-to-day practices. Thank you.
Thank you, Bharti, and thank you, Madhya Pradesh, for their good and great experiences. We all know that there are three different but very important bridges in our facilities. One is a labor room, second one is our newborn care unit, whether it is a SNCU, whether it is a NBSU, and third one is our DEIC or RBSK part. So we need to create a strong linkages between the labor room and SNCU, and from SNCU to DEIC part. So this is the very important thing that we all need to work together for survive, thrive, and transform. Now we would like to move from Madhya Pradesh to the Bihar. So I would like to request Sashi Prabha from Bihar to share her experience about a success story. So Sashi Prabha, please.
Yes. Yes. Good morning. Good afternoon to all. I am Shashi Prabha as SNCU in charge Sadar Hospital, Samastipur, Bihar. SNCU was established in 13th February 2016 with 12 beds. Initially, there were very few admissions in the SNCU because we were not able to manage sick newborn and referred many sick newborn without proper management because lack of knowledge. Later, we all nursing staff and doctors got the PHC training and 14-day observership. At present, we are able to manage all sick newborn. Now, SNCU Samastipur has 16 beds with bed occupancy above 80%, support of UNICEF. We are handling every sick newborn according to protocol of Government of India. I am here to share a successful experience which we manage as a teamwork on 28th October 2020. Female baby came with complaint of no cry, lethargic. We receive on premium bed, check SpO2, connected oxygen with support of Nation Kanuna, check CFT and glucose level. IV cannulation Done as per doctor's instruction, IV fluid 10% extra was given. Suddenly, baby had first episode of subtle seizure. Immediately, anticonvulsant drug injection phenobarbital 20 mg is low given to 20 minutes. Baby was monitored, continue. Baby condition was explained to mother and their relative. Timely family participatory care counseling was done. Baby started crying in the evening. Sucking reflex was present, counseling done to mother about breastfeeding technique. Breastfeeding started under supervision. There is no further episode of seizure. Baby passed urine. On second day, baby was active on continuous monitor. Fifth day, baby was shifted to step down. And, and on the baby, this stable, baby was discharged. At the time of discharge, family was concerned about visit follow-up, care were given green card for community follow-up by Asha. With proper counseling of danger sign, explosive breastfeeding up to 6 months, thermal protection, proper hygiene, hand washing, cord care, counseling for regular facility follow-up, give emergency contact number, and counseling of family planning and organization. Every month we are organized monthly review meeting in that we are discussing about mortality and death review rate. And it was reduced after receiving FBNC training and proper following protocol of Government of India. We work as a team, and at present I am happy to say that we are maintaining morbidity and mortality rate decreased. So far, we have done to facility follow-up of the baby and SSU data entry operator call the family and ASA for the family community follow-up of the baby. We have on this kind of number of case studies, but I have presented only one case. Key of our success in our teamwork. Thanking you all for giving me this opportunity to share our experience. Thanks.
Thank you, Shashi Prabha, for your experience sharing. Now we would like to move towards the West Bengal. So I would like to request Sutapa Banerjee and Mosmi from Tufanganj to share their experiences. Ms. Sutapa Banerjee.
Thank you, sir. Good afternoon, everyone. I am Shutaba Banerjee, staff nurse from Raiganj Government Medical College and Hospital, Uttar Dinajpur, West Bengal. Thank you for allowing me to speak in this August webinar. I would like to highlight some good practices prevalent in our SNCUs in West Bengal. First, early initiation of breastfeeding. We have introduced it not only in labor room but also in OT. The cesarean team is assisted by a nurse who helps the mother to hold the baby immediately it is delivered and breastfeeding is initiated, while the surgeons go on with their work. Secondly, we have individual maternal and newborn mentors who are the faculties of MCH and visits us regularly. During lockdown, they are doing web mentoring with us. We have WhatsApp groups where we send messages and pictures. If we have any problem, our mentors, even our state mentors, also respond to that. In addition to this, we have nurse mentors from nursing schools and colleges who are always mentoring us. Thirdly, we have a system of indenting entire quarter of medicine and other things 1 quarter in advance, which allows store and super to procure the entire stock and provide us. That's why we do not have any shortage or out of pocket expenditure in SNCUs. This process is centrally monitored by the FBNC cell of the state. Fourthly, every week on a fixed day, we have child death reviews, which is chaired by our superintendent and attended by all doctors and nurses from gynae obstetric, pediatrics, and SNCUs. Deaths are analyzed for what went wrong and rectification is initiated. This improves the systemic gaps and fixes responsibility. Lastly, we had central training for nurses on infection control, where we have gained new knowledges like scrub the hub, unidirectional mopping, and autoclaving procedures step by step. One nurse in each shift is designated as infection control nurse who supervises the infection control measures in that shift, demonstrates hand washing and gowning to the mothers. In short, these are some good practices which have improved newborn survival at our hospitals in West Bengal. Now, I am requesting Srimati Moushumi Pal, Sister in Charge of Tufanganj Subdivisional Hospital, Coach Bihar, to present a case which is a great success story at that remote place. Over to Moushumi. Thank you.
Thank you, Shutopadi, and good afternoon, everyone. Tufanganj Subdivision Hospital is a remote hospital situated in Assam border. In spite of all difficulties, we try to keep the newborn survived according to the protocol of Government of West Bengal and Government of India. I am glad to share a case which was very critical. A second gravid antenatal mother referred from an interior place of Assam border delivered a 620-gram baby in 29 gestational weeks. At the time of delivery, the doctor of SNC was present at labor. After birth, skin-to-skin contact and delayed clot clamping done at labor. Though 620-gram baby is not treated to level 2 SNC routinely, but we do this because the nearest medical college, which has a NICU, is more than 200 kilometers apart. After admission at SNCU, all the procedural management was given to prevention of hypothermia. On first 15 days, baby was on respiratory support, that is continued oxygen inhalation by hood. Another 7 days, intermittent oxygen therapy, and then oxygen inhalation given when needed. At the meantime, postpartum psychosis of the mother developed. The family member and the mother left the baby in the hospital. This is also a reason why we were compelled to treat the baby at our facility. So, in the third week, the baby was 640 grams. The mother and the family members were called for counseling, health teaching, and KMC technique. Then KMC was given 9 hours per day under supervision of nursing personnel. On the 5th day, weight of the baby was 600 grams. Then oroglastic feeding started in small amount. Gradually, amount of OG feeding was increased. After that, age of day 21, IV fluid was totally stopped. At day 51, weight of the baby was 1 kg. Then cathode spoon feeding also tried with OG feeding. From day 73, the baby was completely on cathode spoon feeding and breastfeeding. Then weight was 1.3 kg. When the baby was above 1.5 kg at the age of 82 days, then the baby was discharged after RP scanning and OA scanning, and the baby is on regular follow-up. So the key message is small infants can be managed in a small hospital if adherence to protocol is followed, minimum intervention, early enteral feed, and KMC are highly effective. Thank you, Government of India and Government of West Bengal for giving us this opportunity. Thank you.
Thank you, Sutapo and Mosami. This is the nice to hear from your West Bengal that you all are managing all these things. The thing which you have shared is very great, that instead that the care of 620-gram newborn is not and should not be treated at that level 2 SNCU, but many times we all are faces that patients are refusing. So I can say that, and they managed these kind of newborns, and I have discussed with the nodal officer of the Dr. Roy also, and they said that they, and each and every states, we are constantly in discussion with all the state nodal officer, and they all are saying that we have n number of success stories of the survival of the newborn. But we can say that we need to promise ourselves that we need to give our 100% efforts for the newborn survival, not only for the survival, but thrival and transforms also. This is the good thing. Now we need to move towards the
mute.
Utapa, please mute yourself. Now we would like to move the another session, which is a question answer session. But at the onset of this session, I would like to request all the panelists of the question answer session should need to be very short, because we are over the time, and now the time is around the 5 o'clock. So we have only 5 minutes for this question answer session. So this is our request to please be short. Now for the next session, I would like to request Rati Balachandran to please continue the session.
Thank you, Dr. Kapil. So today we have heard from the practitioners and from the field that how they are taking care of babies and ensuring the safety and quality and equity for the babies. We have 5 experts in the field of 5 nursing experts are available with us. Let us hear from them. That we all know that every mother is having a dream of having a healthy baby. And we know that the health of the baby depends upon the attention they get right from the pre-conception and throughout the antenatal period. Let us hear from the nurse practitioner midwife, Mitali Adhikari. She represents the Society of Midwives India, and she is an advanced trained in midwifery from various international platforms and is also leading this force today. Over to you, ma'am. How the midwives, nurse practitioner midwives are ensuring this for a healthy baby for the mother.
Good afternoon, everybody. And I would like to give the thanks to Minister of Health and Family Welfare for giving this opportunity. Though the time is so short, so I am making also short in my speech also. Pregnancy and childbirth are the normal events in the life of women. Healthy mothers bring healthy child. The survival of mothers and newborn is closely correlated with the care, attention, counseling received during antenatal, childbirth, and postnatal period. Delays in identification of complication, lack of access of skilled care, or delayed management are the important causes of maternal and neonatal death. Therefore, women-centered, individualized, compassionate, and quality of care is needed throughout the pre-pregnancy, pregnancy, childbirth, postpartum, early weeks of the neonatal period. And it should be the respectful care. Evidence shows that quality care can be rendered to mothers and newborns by NPM, who are the skilled professional and who are specifically as per ICM and WHO international standards to provide quality antenatal care, quality internatal care, and quality postnatal care. So this is the right of the woman also. So NPM should and during the antenatal period, NPM should assess the mother, identify the problem, manage the problem, and refer the problem in the first referral unit with the prefixed transport linkage facility. They should counsel the mother regarding the importance of antenatal checkup. Diet is an important factor having with the mothers and the newborn also. So they should counsel the diet, rest, nutritional supplements like the IFA tablet and the calcium tablets also. And they also counsel the birth spacing and the new term that is BPCR, birth preparedness and complication readiness. And along with the institutional delivery, and they counsel during the antenatal period regarding the newborn care, like skin-to-skin contact and early initiation of the breastfeeding, because it is needed after the birth of the baby. So thank you so much, ma'am.
Thank you. Thank you, Mitali, ma'am, that how the empowering mother will help and helping, educating and counseling them regarding nutrition and proper care during antenatal can prevent preterm delivery, and in collaboration with the neonatal nurses and good attention at the time of birth can save the babies. Even the babies are delivered safely, and they can at the home, they will be with the mother at the home settings, but they require constant monitoring. So that is monitoring of the mother and supervision of the mother in taking care of babies provided by a battalion of ANM and LHVs available in the field. So we to explain the role or how the ANMs are supporting in ensuring the mother in taking care of baby, we have Buluma Saikia. She is the president of All India Federation of ANM and LHV with us. Buluma Sakia, can you just explain that how you are helping in ensuring quality and equity of the care out to the baby and newborn and safe ensuring the safety of the baby? Buluma.
Thank you, madam. Good evening, everyone. I am Buluma Saikia, LSV from Assam. Presently, contribution for providing quality neonatal care in the field for prevention of neonatal mortality. The ANM and LSV are present, play critical and crucial roles in prenatal, neonatal care at all levels of the health system. Assam remain among top 3 states in the country with the highest infant mortality rate. However, ANMs are trying their best to improve the situation. home visit and line list pregnant women for early registration, to proper antenatal care services in community. All the national programs related to neonatal care are implemented by ANM LSB or supervisors, help to spread the knowledge and skill that these national programs among ANM and ASA along with state nodal officer. Health education on maternal health, nutrition, immunization for tetanus, safe and clean deliveries and care of newborn to provide home-based newborn care. Counseling for regular checkup and institutional delivery. Follow-up and update of all postnatal mother through phone call and home visits. To improve the care of babies at the time of birth by improving the knowledge and skill of ANM LSBs. Take care of low birth weight baby in KMC. Counseling mothers about breastfeeding. Whenever we find any critical neonatal baby, we refer them FRU and hospitals. Help in arrange hospital and ambulance for refer. Regular home visits for after delivering during the months with the child and manage minor illness and pneumonia. Aware to family knowledge of danger, sign of infant and take care immediate. Improve occurs to water sanitation and hygiene of mothers or family members. Meeting separately with ANM and ASA for providing quality care during mother counseling regarding breastfeeding, breastfeeding technique, danger sign of newborn, immunization, baby care, kangaroo, mother care. Association organized state-wise conference, workshop, skill training on IMCI program, KMC, immunization program, breastfeeding program. Association celebrates state-wise all neonatal program launched by Government of India, especially breastfeeding week celebration by organizing workshop, rally, group meeting with mother and also organize neonatal conference yearly of ANM LSB on the Government of India program related to mother and newborn. Also, ANM and LSB visit families in distance, homeless houses where ASAs find it difficult to counsel the family about deferral to health facilities for care, seeking adoption of healthy practices. Last but not the least, the neonatal mortality rate has declined from 44% 100,000 live birth in 2000 to 23% 1,000 live birth as per sample registration survey 2018. This is done to the hard work and dedicated contribution of ANMs in the field through mother meeting, health education, awareness, and motivation program conducted through BSND and house visit throughout the year. Because 70% of population in India lives in villages and most of them are poor pupil.
Thank you. Thank you. Thank you, Bully Mama. How you are leading the community with the community participation. You are empowering the mother and helping them to take care of the baby is explained very well, and how you are providing the capacity building to the ANMs are also explained. So, but the babies are very delicate, and in some situations their condition may worsen, and if they need, if their health deteriorates, it requires specialized health, specialized care, and there comes the role of neonatal nurses, and the facility-based care may be required. So we have the Professor Jyoti Sarin. She is the president of Indian Association of Neonatal Nurses with us. Now we can hear from her that how the IANN is contributing towards the capacity building of neonatal nurses. Over to you, ma'am. Ma'am Jyoti Sarin.
Thank you, Dr. Rati Balachandran, respected dignitaries on the platform, and dear neonatal nurses. Greetings from Indian Association of Neonatal Nurses. Indian Association of Neonatal Nurses was constituted in 2008 to advance the knowledge and skills for fostering excellence in the practice of neonatal nursing. for strengthening pre-service and in-service education and creating pool of trainers, training of trainers on NRP and FBNC are periodically organized. During annual conferences, pre-conferences with hands-on experience on essential components of newborn care versus non-invasive ventilation, prevention of hypothermia and KMC, care of low birth weight babies, evidence-based practice, and developmental supportive care are held. In main convention, recent updates with research evidences and sharing of quality initiatives are deliberated. Free paper presentations are held. Out of that, 3 best research papers are awarded to promote research and discipline of neonatal nursing. INN remains committed to support implementation of quality initiatives and dissemination of its outcome to improve intact survival of small and sick babies. Indian Association of Neonatal Nurses join fellow healthcare professionals and has an important and collaborative role to play in developing and updating the teaching learning resources and effective implementation of the policy and programs of the country to attain the highest level of health for neonates and mothers. The way forward for INN is development of standards for neonatal nursing, developing online certificate course for in-service neonatal nurses. And thereby, I salute all the neonatal nurses for contributing significantly in improving the positive neonatal outcomes. Thank you.
Thank you, Jyoti Srin madam, but I am not feeling good to share this thing that now we need to close the sessions because there are 2 more experts with us, and I want to say from our end that Pitti Kaul madam is there, Director of School of Health Services, IGNU, and Sri Devi madam is also available with us as an expert panel, but because we are running behind the time, 20 minutes we are running behind the time, so we need not to take 2 more questions from our esteemed experts, Preeti Kaul and Sri Devi madam. Now, I would like to request Rati Balachandran madam to kindly say vote of thanks. Madam Rati Bala, please say vote of thanks to all our participants.
I'm extremely sorry that we are cutting short the program, but I am thankful for the Ministry of Health Child Health Division for giving us an opportunity and architecting this webinar, which was a real enriching experience for all the nurses. We are the nursing fraternity would like to partner in all the neonatal activities and commit ourselves towards reducing neonatal death and in achieving SDG goals. Thank you. Dr. Kapil, thank you very much for all the supports right from the beginning of inception of this idea and bringing everyone together and giving this platform. WHO is also appreciated and acknowledged. Thank you very much. The Child Health Division under the leadership of the...
Thank you very much to all the participants who have attended this wonderful webinar, which is now we can say we have a small request to all the participants that on 21st of November we have another webinar on the facility-based newborn care, do no harm. Our esteemed speakers on that 21st November webinar will be from AIIMS New Delhi, Dr. Ramesh Agarwal, and from AIIMS Jodhpur, Dr. Neeraj, and from the RML Hospital, Dr. Aarti Maria. They all, the 3 experts will be talking on the different topics. So we all are requesting to kindly log in, register yourself for 21st webinar also. Thanks a lot for all the panelists and our additional secretary Manohar Ragnani sir, Sumita Ghosh madam, Rati Balachandran madam, and all esteemed panelists and participants. Thanks a lot.
Thank you, sir.
Madam Sridevi. And